غايدات تاخذوا لكم بريك كويس يعني ثلث ساعة إن شاء الله 25 دقيقة. يلا مين بده يساعدنا بالسلايدات؟ أنا ساعد أنا بحالي قبل ما يجي زميلكم. Okay. So we will talk now about peptic ulcer diseases. So we'll talk about the definition, comparisons, clinical presentation, management, and emergency scenarios. What's the peptic ulcer disease? Peptic ulcer disease is an erosion in the mucosal lining in the gut, any portion of the gut GI tract, circumscribed ulceration in the GI tract, mucosa exposed to acid and pepsin, and most often caused by Helicobacter pylori. Zaman, when I was in the school, they were saying no acid, no ulcer, but nowadays no Helicobacter, no ulcer. So اختلفت. So most of the time, around 90% of the cases, Helicobacter is the cause of the ulcer. Okay, gastric ulcers, the ulcers that occur in stomach lining, some of them they might be malignant. So when we do an endoscopy for patients and we find gastric ulcers, we tend to take biopsies from these ulcers because they are at higher risk of developing gastric cancers rather than duodenal. أحيانا duodenal ما بناخذ منهم شيء بنشوفهم منظر على العين. Okay, next. The most common peptic ulcer is in the duodenum, more than 95%. This is the normal esophagus and stomach. Esophagus, cardia, fundi, antrum, body, and pylorus. Next, please. You see why this is important. Slide is important because about the pathophysiology of the peptic ulcer. So this is the membrane phospholipids that start with phospholipase A2 that will give you the phospholipase A2 that will use the phospholipids within the membrane to produce arachidonic acid. Arachidonic acid is in the top of the hierarchy and the pathway that later on with the COX-1, COX-2, cyclooxygenase 1 and 2, they will be important in the protective line, in the protection of the lining of the stomach and the GI tract and the mucosa. COX-1 is a housekeeping enzyme we can find in the stomach, protect the stomach, find it in the kidneys, quite important in the afferent, doing afferent that will produce prostaglandins responsible for afferent dilatation. So that's why when patients they have NSA, they might have renal injuries and nephritis and ATN because of the vasoconstriction and ulcers. Platelets, thromboxane A2 is important in platelet aggregation, and they are as well found in the endothelium release in the endothelium to maintain hemostasis when there is a bleeding. COX-2 is only released in inflammation, responsible for inflammatory response, found in macrophages, leukocytes, fibroblasts, and as well as in the endothelium. When there is an injury, the COX-2 will be the dominating enzyme. When there is no injury, the COX-1 will be the housekeeping and the dominating one. Okay, so thromboxanes, بس come back, بس نرجع سلايد سريعا لو سمحت. سلايد قبل. Thromboxane, prostaglandin E2 and prostaglandin I2 are quite important in mucosal integrity, platelet aggregation, renal function, inflammation, mitogenesis, and bone formation. Next, please. This is a slide. It's important as well why we understand that the stomach and the intestine, they are innervated by the vagus nerve, the parasympathetic, and there is a few receptors and few stimuli that will stimulate acid secretion and suppression. So there is D cells that we can find in the parietal cells in the fundi. D cells, they act as a negative feedback to the parietal cells. They will suppress the acid secretion, the D cells. So if it's activated by the parasympathetic through the acetylcholine. So the acetylcholine will suppress the D cells. So what does that mean? The parasympathetic system is used and the sympathetic هو ما يسمى بالكر والفر. Imagine if you are in a jungle and a lion is running after you, your sympathetic will take over. But إذا إنك مرتاح, sitting in the home, ماكل, شارب, مرتاح, نايم, the parasympathetic will take over. So the parasympathetic will suppress the D cell and it will activate the parietal cell in order to produce acid in order to digest لأنك أنت مرتاح ومروق. Okay, so acetylcholine will suppress or will negatively feedback the D cell okay, that will affect the parietal. So, which like نفي إثبات, which means as you are activating the parietal. In addition, it's activating directly the parietal. That's quite important. Why? لأنه زمانات in the old days, they used to do vagotomy. يعملوا vagal nerve cut from the stomach to treat peptic ulcer. زمان كانت البيبتيك ulcer treated surgically. Now triple eradication therapy انتهى الموضوع. So can they do vagotomy because the vagus, as you see now here, it's quite important in acid and pepsin release. Okay. So we have another these cells, ECL cell, شو ممكن ناخذ شوية وقت عليها, enterochromaffin-like cells, which is secretes the histamine, and we have H3 receptor, H2, H1 and H4. H4 ما بنستخدمه كثير, but H3 is quite important as well. Negative feedback in the D and positive feedback in the H2 in the parietal cell. That's why when we treat as well ulcers, we can give two H2 blockers, which are like ranitidine, famotidine, cimetidine. Cimetidine is an old-fashioned, a lot of side effects, a lot of potent liver CYP34 inducer. نعم نستخدمه a lot of interaction with other drugs. ranitidine انسحب, بجوز سمعته قبل كم من سنة because of carcinogenic effects. So ظل الفاموتيدين, والأحسن منهم البي بي ايز حاليا. Okay, Vegas as well innervate the antrum. G cells are responsible for the gastrin, acetylcholine, and the gastrin releasing peptide, which comes. So parasympathetic sometimes act like not just a neuro. There is a neuroendocrine thing, neuroendocrine interaction. So GBR is per se it's peptide, it's a hormone. How so? It's why it's delivered. It's affecting why it's released by the presynaptic nerve, vagus nerve, innervating the antrum. Okay. تلفوناتكم اوف يا جماعه. No side talks. تلفونات اوف. عددكم قل. طيب. هنشوف مع الدكتور غيدار شو راح يصير. Okay. G cell. So the G cell positively feedback to the D cell, and زي ما حكينا D cell وظيفتها انها تعمل suppression للاسيد. Okay, through the somatostatin. The Helicobacter and the chronic antrum, they will suppress the D cell, chronic Helicobacter infection. With acute, they will affect as well. They will suppress the D cell, and this will further increase production of the acid. So infection by Helicobacter, direct injury by the bug, the bacteria itself, plus acid and pepsin, this will result eventually in peptic ulcer disease. Next, please. This is another slide about what's going on and the parietal cell. Why now they concentrate more on the H and the hydrogen potassium ATPase, which is suppressed by the BBIs. So the BBIs they act on the hydrogen potassium ATPase, thus and eventually hence reducing the acid secretion. And you look, somatostatin in the D cell relief, it will suppress the parietal cell and the ECL cell from releasing the histamine. So histamine has an important role as well as gastrin and other interaction. A D cell will suppress the G cell. So the G cell, the gastrin will go through, like, because it's an endocrine cell, even from the antrum, it will go through the blood vessels to the fundi, to the parietal cell, okay? So it's an endocrine thing. So what's the difference, by the way, between endocrine and paracrine function? In English, yeah. So the secretion, the hormone will go through the bloodstream to the targeted cells, to the adjacent cells without the need. So this is an endocrine, though the cells, they are not far from each other. So it's not a paracrine, so it's an endocrine effect. The other ones, they are paracrine. So, and you can name them. Next, please. Okay, so this is basically how things occur in H. pylori and how the ulcer occurs. So first, in the H. pylori, high level of acid production will help the H. pylori to survive, we know that that's why we give acid suppression, because with the acid, with the H. pylori infection, this will lead to gastritis in the antrum and eventually antral duodenal ulcer if it goes into chronic H. pylori. So H. pylori presentation may be asymptomatic, may be symptomatic acutely, and might be chronically symptomatic. So it depends on the stage, okay? In chronic H. pylori non-atrophic band gastritis, that ما عندنا أي symptoms, and when it's asymptomatic we do not treat. So it's في two approaches, more in the pediatric test and treat, بس بالapproach الكبار if it's asymptomatic ومش عملت لنا مشاكل we don't treat. But إذا عملت لنا مشاكل we treat, okay? يعني إذا عملت لنا gastritis, dyspepsia, ulcer to the further to the severest extent ulceration. Gastric ulcers might cause intestinal metaplasia, healing again, dysplasia and gastric cancer. So it's more the Helicobacter and H. pylori. If you see a gastric ulcer, you should treat even if it's asymptomatic. ممكن في الduodenal ulcer, wherever there is ulcer you treat, but if it's gastric ulcer you will be more aggressive وما بتستنى. Okay. NSAID induced. So how the NSAID, the aspirin, for example, ibuprofen, they do ulcers. First of all, the ischemia, because as we mentioned the second slide, they suppress the production and the production mainly of prostaglandins, where they maintain the integrity of the gastric mucosa. So number one, and they will cause vasoconstriction. So you'll have an ischemia. So the mucosal, the underlying submucosa and the mucosa, they will be ischemic and friable easily, which means they will slough easily. Direct toxicity, when you take it, there is an iron toxicity. So NSAIDs do injury in two pathways, in two ways, either direct or indirect. احفظوها هاي. Either direct by ion trapping, it will cause direct injury to the cell by ionization of the cell. Indirect injury by all of what's mentioned, epithelial, suppress the mucin secretion, because as well the mucin and the mucus secreted by the goblet cells are regulated by the prostaglandins. Decrease bicarb secretion, which is protective, a layer to make it more surface active phospholipid and epithelial cell proliferation, because it's important in the growth and the life cycle of the enterocyte, and eventually we'll have an ulcer healing or erosion. So the ulcer is, what's the difference between ulcer and erosion, Jamal? Any ideas? And when we say for gastric erosion, gastric ulcer, طب ليش مغلبين حالنا? Why we bother ourselves with this stuff? ليش ما نقول نحكي just ulcer? Ulcer usually is involving submucosa, sometimes to the to the muscularis might go. So the ulcer might penetrate and might proliferate. The erosion is just the mucosa affected. Okay. Next. Pathogenesis, non-Helicobacter, non-NSAID ulcers. في عندنا other causes other than to lesser extent than Helicobacter and NSAID. The most common اللي حكينا عنهم. Cytomegaloherpes simplex and Helicobacter helminthi, which is part the same. طبعا mechanism of injury often is almost the same pathways. Okay, it's all about gastric acidity, direct injury, and recruitment of inflammatory cells. Okay. Toxins, bisphosphonate, chemotherapy. Bisphosphonate, their more side effect is esophageal reflux esophagitis. That's why when we prescribe bisphosphonate for osteoporotic patient, we ask them to take it first thing in the morning, يشرب مي بعديه, and walk, keep upright, because if he sleeps or if he lies flat, this will be a reflux, and the reflux will be very severe, very nasty, reflux esophagitis. Remember the side effect of bisphosphonate. Chemotherapy, clopidogrel, which is an antiplatelet. Crack, cocaine, يعني الناس برا أكثر من هون, بس might be cocaine causes vasoconstriction. كنتوا تنتبهوا لهذا الموضوع. That's why it might chronic use of cracks and might cause cocaine ulcers. Glucocorticoids quite important. Patients لما يدخلوا patients احنا في respiratory بنعطي كثير steroid, بنعتمد على steroid كثير, and sometimes when they are critical يعني in the ICU admitted you have يعني تعطيهم steroid plus إنه في عندك stress, something called stress ulcer. From the stress they will develop, so you have to give them GI protection through by BBIs. MMF, mycophenolate, potassium chloride. Other diseases, basophilia, infiltration, duodenal obstruction, annular pancreas might cause that because eventually it will compress the vascular bundle and causes ischemia like a ring. Okay, infiltrating disease, ischemia, radiation, and sarcoid, Crohn's, and idiopathic secretory state. You can name under this. Next, please. Test for H. pylori quickly, rapid urase, invasive. So in your rapid urase, when you do the endoscopy, we take enteral biopsies. But then we will see in a couple of slides, there is a kit, easy kit, rapid one. You put the biopsy or the spirit from the antrum from there, and the color changes from yellow to red, which means there is a urase enzyme that changes the color. Okay, so it's positive. It's high sensitive and highly specific, but might give you false negative if the patient on the BBI or bismuth compound. So أحيانا you might ask the patient to stop BBI 1 week before if he is tolerating. If not severe epigastric vein, لا بتعمل الاندوسكوبي على BBI. But if he is tolerating 1 week before مشان الريزلت تطلع more reliable. Okay, histology 80-90, yeah, but it takes time consuming. للأمانة sensitive and specific. You send from the antrum, تقول للمريض ارجع لي بعد 10 أيام. It takes 10 days sometimes, but it takes time consuming. But the rapid urase on spot, هو المريض تأخذها تخلي الممرضة والممرض اللي معك يروح يعملها رأسا، بتقول له positive, it's positive, you treat. Okay, and you don't, يعني وما بتهتم if it's chronic or active or acute, because whether it's there and he's symptomatic, لأن البيشنت قطعا تعمل له لما كان symptomatic مش screening. Okay, culture time consuming بطلنا نعمله. non invasive serology بتعمل الاي جي اي والاي جي جيز. هيليكوباكتر اي جي اي بتدلك انه recent infection. اي جي اي جي يعني within first 6 months recent infection 6 weeks sorry more than 6 weeks IgG start to rise and past infection recent infection or chronic infection. inexpensive convenient ممكن نستخدم later on في الكورس بس not early in the follow up and diagnosis. Urea breath test is quite good as well. You ask the patient to breathe because why? Because the Helicobacter contains the urease enzyme which will break the ammonia into urea and it will be detected. في عندنا كمان stool antigen inexpensive inconvenient بس مش موجود للأسف في كل المناطق بس it's good. These are non-invasive quite good إذا كانوا موجودين وبيساعد في diagnosis. Next please. Drugs acid suppressing antacids جافلسكون وهاي الأمور مش راح نحكي عن الدوزز. H2 receptors, we mentioned that because the histamine has an important role and in the activation and acid secretion. BBI, which acts on the potassium hydrogen pump, so the potassium will be secreted into the gut and they will keep the H plus because of the H plus is released means more hydrochloride and gastric juice. So this will inhibit this type of bump in the basal membrane of the parietal cell. Okay, mucosal protective agents such as sacralfate, prostaglandin, allo, misoprostol, and bismuth compounds. Next, please. This triple therapy. So you have heard about the eradication therapy, which is triple therapy, 2 antibiotics plus BBI, and there is a quadruple, 2 antibiotics plus BBI plus bismuth compound. You have first, second line, and third line. First line is usually, maybe this is an old thing, but because it contains ranitidine, ما حطيت للأسف نسيت أحط new one. But let's amoxicillin, clarithromycin, and BBI is the omeprazole or either isomeprazole, Nexium اللي هم بيحكوا له. This is the first line. If the patient is allergic to amoxicillin, you can substitute the amoxicillin by metronidazole, which is a flagyl. Okay, so for the triple. For the quadruple, either the same triple plus bismuth compounds, or we go toward the second one, which is levofloxacin-based line. You use levofloxacin, coamoxiclav, or amoxicillin, BBI, and bismuth compound, or with or without bismuth compound. Couple of things, but they are the most. When you open the literature, there are a lot of probably trials of different things, but all of them they will be around amoxicillin, clarithromycin, flagyl, levofloxacin to lesser extent. Probably the third line levo will be substituted by doxycycline. Okay, next. Active ulcers. So what's the recommendation for NSAID-related mucosal injury? When a patient has an active ulcer, NSAID should be discontinued. You can give famotidine or BBI, or if you can't stop the NSAID for a reason or another, you need to put him in BBI, and we give him as well prophylactic therapy, misoprostol, which is a prostaglandin analog to protect the BBI. And we try to give a selective COX-2 inhibitor, which is safe, gentle, and stomach-friendly NSAID. Okay? Your eyes بالمحاضرة يا جماعة. اتركوا التلفونات. No WhatsApp, no messages. Turn off الموبايلاتكم إذا سمحتوا. H. pylori eradication infection إذا وجدناها we have to eradicate لأنه synergistic effect with NSAID. Next please. Again, guide to NSAID therapy. Later on it will be like شوي confusing when you will be an internal medicine. It will be challenging whether should I stop, should I continue. No cardiovascular risk, no aspirin, traditional NSAID. Try إذا كانوا low risk for GI bleeding. يعني not all patients when you prescribe, for example, for cardiovascular patients, it's quite used aspirin, quite common. So مش كل واحد على aspirin should be started in BBI. هاي بدكم تعرفوا. You ask him, is he low risk, مدخن مش مدخن, عمره, previous history of peptic ulcer diseases, any epigastric pain, gastric erosion previously, concomitant use of NSAID for joint pain or osteoarthritis. Okay, we start doing that. دكتورة اسمك عفوا شو تساوي؟ ممكن تشاركينا بشو تساوي؟ ممكن أعرف؟ تلفوناتكم إيش؟ إذا بدكم تلفونات ممكن تغادروا عادي، تحكوا مع بعض براحتكم بدون تلفونات، ما عندي مشكلة. أظن إني نبهت أكثر من مرة. Okay. Cardiovascular risk, and there is an aspirin, and he is low risk for NSAID. You consider BBI or misoprostol, but إذا في عنده NSAID GI risk قبل هيك صار معاه risk ulcers from NSAID and he is on aspirin, he should be first in BBI, and NSAID should be selective COX-2. وبدنا نحاول إنه إذا قدرنا كمان إنه نخلص من النسيد ما في عندنا أي مشكلة. Okay. ثواني يا جماعة بس. مرحبا غدا، كيفك؟ الله يسلمك، حياك الله. اهلا دكتور غدا. انا تقريبا ان شاء الله يعني اذا بتكوني هون 12 وثلث كويس، يعني انه خلينا 12 ونص، انا تقريبا يعني بدي ساعه او اقل ان شاء الله بكون مخلص ان الله غدا. ماشي. بعطيهم اكيد ان شاء الله، ربنا يسهل. سلام. سوري دكتور غدا. Okay, so new onset dyspepsia, that's quite important. When the patient presents to the clinic with a new onset dyspepsia, with a heartburn symptom, indigestion. So, and he is more than 40 years old and he got an alarming symptom. What are the alarming symptoms we know? What are the alarming symptoms you know in a patient with dyspepsia? And when you will be alarmed when a patient with dyspepsia comes to your clinic and will look, I got this heart pain, epigastric pain. When you will be that much concerned and when you will be feel relieved and you can send him home without minimal interaction. If this epigastric pain, if there is a epigastric pain that awakes him from sleep, weight loss, night fever, for example, bleeding, hemoglobin low, yes, okay. So you should be aware of that. So what will we do? By history, we'll exclude if there is any gastroesophageal reflux disease, biliary pain, IBS, erophagia, and medication related. They will do if the history is negative, we'll do the non-invasive Helicobacter pylori. And if the non-invasive, they are positive, we treat for Helicobacter pylori, we eradicate. 4 weeks after therapy, confirm eradication by urea breath test. Okay? symptoms remain or recur, we send them to the gastroenterologist for endoscopy. We don't wait. يرجع بس السلايد سمحت قبلها. If the new onset dyspepsia وعنده alarming symptom من البداية, we send him to the GI because he needs endoscopy. Some of the approaches أحيانا we put them in BBI for 4 to 6 weeks. ما تحسن, send him for endoscopy definitely. Okay, next. مش طالع بالغلط. So yeah, pathogenesis, protective factors versus hostile factors. Okay. H. pylori, gastric acid, pepsin, NSAID. They are when there's protective factors, they outweigh the hostile factors or the injurious factors. They should be the mucosa will be healthy. But when the hostile factors increase, the other protective factors outweigh the protective factors. Ulcers will develop. Okay. دكتورة ودكتورة غادروا إذا سمحتوا القاعة. دكتورة واللي جنبك. أنت نعم. بغض النظر. لأني حكيت لك وسألتك وقلت لك شو بتعمل. وإذا سمحتي واللي جنبها الدكتورة اللي جنبها إذا سمحتي غادرة معها. Next slide. Etiology of peptic ulcer disease. Normal increased attack of hyperacidity, pepsin and NSAID, weak defense زي ما حكينا. Next, stress, drug smoking, they are quite important as well. Okay, this is لما يكون عندك your protected well ما في مشاكل, but once your defense mechanism started to weaken, you will have this thing. Okay, next. This is a brief schematic slide about what's going on and how things occur. It's all about repetition. It's parietal cell hyperplasia, acid secretion more, gastric ulcer, vehicle stimulation. So when we're treating the gastric ulcer, the peptic ulcer disease, we should bear in mind all of these pathophysiology and mechanisms, reduce alkaline and eventually erosive gastritis, just affecting the mucosa and slightly little mucosa, and if it reaches the muscularis, the mucosa and below, this is an ulcer, proper ulcer. Okay, next. The same thing, the same offensive mechanism. Next. Alarming symptom, unintentional weight loss, progressive vomiting, dysphagia, odynophagia, unexplained anemia or iron deficiency anemia, because usually it's quite common in adults and pediatric, unexplained iron deficiency anemia. You have investigated everything, وما في ولا شيء, you should think about H. pylori. H. pylori causes uninvestigated, unmasked, unexplained anemia, iron deficiency anemia. Hematemesis, probable abdominal mass and lymphadenopathy, family history of upper gastric, they were more liable to have gastric cancers, previous gastric surgeries and jaundice. Usually these previous gastric surgeries, sometimes they will develop ulcers and gastric and dysplasias at the site of the anastomosis, usually. So you have to bear in mind this important thing. Duodenal ulcer versus the gastric. Duodenal sites are far more common, 95% than the gastric ulcer. Middle age 30 to 50. Male to male ratio is more in male, and 4 to 1, and duodenal ulcer 2 to 1 in gastric. Blood group A is, for a reason or another, it's more, the gastric ulcer is more common in blood group A, we don't know why. NSAIDs more fourfolds. More in blood group O, the duodenal ulcer associated with increased serum pepsinogen. H. pylori is 95%, smoking is twice as common, and 10 to 20% of gastric ulcers, they will have concomitant duodenal ulcers. So once you see the gastric ulcer ما بتوقف, you try to go to the D1, to the duodenum, to the first part of the duodenal, لأنه غالبا 20% من الحالات you might find duodenal ulcer. I know that the treatment is the same, but for the documentation purposes. Okay, next. حكينا incidence more common in duodenal, less common, acute, chronic usually in gastric, benign or malignant. They might develop structures كمان. Causes Helicobacter pylori in more than 80 to 95%. Stress, surgery, emotional, smoking, excessive acid secretion, chronic use of aspirin, NSAID, and glucocorticoids. Sometimes, very rarely, something called gastrinomas. which is parietal cell, or G cell benign tumors, when there is a proliferation of that, excessive gastrin secretion, hypersecretion, and excessive acid secretion as well. Next, please. It is very rare. Yeah. H. pylori, NSAID, smoking, blah, blah, blah. Zollinger-Ellison syndrome, which is a gastrin secreting tumor, blood group O and hyperacidity. Urease producing gram-negative bacilli, H. pylori, flagellated, legionelated, with developing a more common in developing country, infection increases with age, infection mucosa, stomach, inflammatory response, and the whole spectrum. Incidence increase of developing gastric adenocarcinoma more if it comes at the lesser curvature of the stomach. Next, please. No acid, no ulcer, old testament, no helicobacter, no ulcer. This is the new one. Okay. Most common infection in the world, 10% of the men, 4% of the women develop BUD, positive in 70 to 80% of peptic ulcer disease. So peptic ulcer disease, always think about H. pylori, then think about other things. Chronic gastritis 90%, peptic ulcer 95%, gastric carcinoma 70%, which is high, gastric lymphoma MALT, which is called MALT, the one that we mentioned earlier, reflux uveitis, and non-ulcer dyspepsia or non-erosive gastric reflux called NERD. This is the one, yeah. This is our culprit bug. Yes, next, please. Testing, we mentioned urea breath test, stool analysis, antigens, serology, and endoscopy and biopsy. Gold standard. Next. This is the test that I was talking about that will done bedside with the endoscopist, and the nurse will do it for you. You give her the forceps. The forceps will be just diluted in this one. Changing to the red color means it contains urease. Okay, next. And it's quite important when a patient comes with a big gastric pain to have a differential diagnosis for that. Biliary colic, acute cholecystitis, pancreatitis, perforation of viscous acute appendicitis, malignancy. This is the most important thing that we manage. Medical gastroesophageal reflux disease, MIB, and pneumonias, because they share the same innervation. Okay, and they are nearby. Next, please. Symptoms of peptic ulcer disease ranges from asymptomatic to severe bleeding. Sometimes epigastric pain, nausea, flatulence. H. pylori, where it causes IBS-like syndrome. So part of the investigation for IBS. So IBS is a differential diagnosis by exclusion. So you have to do all the list, exclude everything, and the IBS by exclusion. Though there is a Rome criteria. One of your colleagues asked me about the IBS earlier. So part of the investigation for IBS is H. pylori always. Okay, heart pain and pain radiating from the back when there is a penetration, usually often associated with a duodenal ulcer. Penetration, it's not perforation. Penetration means probably affecting the submucosa and the muscularis without penetrating the serosa, without perforating the serosa. So penetration, in the duodenal ulcers, they will penetrate to the pancreas, and these symptoms usually related to penetration ulcer to the pancreas. Okay. Next. Alarming sign for epigastric pain, chronic GI, iron deficiency, anemia, progressive unintentional weight loss, progressive dysphagia. This pain awakes him from sleep. Yeah, this is night symptoms, means persistent vomiting, epigastric mass, age above 55 with unexplained first onset dyspepsia should raise alarm until you investigated and he is fine. So you shouldn't take this. You should take this seriously. Manifestation of peptic ulcer disease, remission, episodes of remission and exacerbation حكينا عنها. GI bleed, possible hemorrhage, perforation of the ulcer, significant mortality. Alhamdulillah, زمان كانت هاي old days. We were not my days, even the days before the innovation of BBIs and the H. pylori and the eradication therapy and knowing what's going on. The patient used to present with the perforated ulcers, but nowadays, luckily, there is nothing like that. And obstruction of the GI tract because of the structures. Yes, next, please. Diagnosis, endoscopy, barium meal. We don't often use that regularly nowadays. Used to do that. It will show some like a bitten mucosa, called bitten mucosa because of the ulcer. Biopsy, bacteria malignancy, H. pylori. You know what we are doing next. Complications, bleeding, fibrosis, stricture, pyloric usually. Pyloric stenosis is quite important. perforation, peritonitis, and emergency, gastric carcinomas, non-duodenal, non-pharmacological. Number one, when you advise the patient lifestyle modification, non-pharmacological, then number two, pharmacological. Yes, avoid spicy food, avoid xanthine containing beverages, avoid alcohol, avoid smoking. دكتورات بس اغلبكم سكروا الباب وراكم. انتم معانا في الطب؟ Okay, let's close the door والله بعديها. Avoid alcohol, avoid smoking, heavy meals, and all these things that might aggravate. Xanthine derivatives are the thiophyllins, الشاي والقهوة والهوت شوكولات بيزيدوا هاي الأمور to bear in mind. And the other drugs that might increase steroid NSAID. Next please. حكينا عن اللاينز treatment 2 weeks زي ما حكينا. BBI clarithromycin amoxicillin for 2 weeks. This is the first line. إذا allergic we substitute the flagyl allergic to amoxicillin. Second line levo containing either triple or quadruple plus bismuth compounds. Usually when you start patient in bismuth compound بدك تحذره, you should warn them that their stool that might color, they will change into black because of the bismuth, which is normal. And if he take the bismuth compound and went back home and his stool color is black, he will panic and he will start feeling and think, oh, I'm bleeding again and blah blah blah, all those stuff. But if you warn him, he will be rest assured and he will continue the treatment. Okay, next please. Functional dyspepsia, if briefly we'll go through that. Functional dyspepsia, from its name, it's functional, which means there is nothing organic, nothing structural through the Rome 3 criteria. Functional, bothersome postprandial fullness, early satiety, epigastric pain, epigastric burning. Sometimes it might intersect with IBS symptoms. No evidence of structural. بعد ما نعمل endoscopy, rule out any organic causes. So, and should be at least 3 months, continuous 3 months in the last 6 months before diagnosis. يعني symptoms should be at least 3 months موجودة. It was come and goes intermittently in the last 6 months. Next. Reassurance, usually treatment, dietary, psychological advice. بتشبه شوي ال IBS جزء من بعض. We give a trial of acid suppression, placebo-like. Sometimes they might improve, sometimes not, especially if they have reflux-like symptoms. 4 to 8 weeks. Next, please. If we find, we do the serology. We don't know that it's a functional now. We treat it as a new onset dyspepsia. We approach it as a new onset dyspepsia. So بدنا نعمل non-invasive H. pylori, and if we find it, we treat it. ما في شيء. وعملنا endoscopy ما في شيء. Then we start saying that it's more functional dyspepsia. Okay. What also we do? Okay, recommended H. pylori. So the American College of Gastroenterology recommends H. pylori eradication. ليش؟ ببساطة حتى لو إنه you don't think that H. pylori is the causative, بس بنريح راسنا. So we treated that part. Okay, so we are quite sure that we eradicate this H. pylori, and these symptoms are now related to the functional dyspepsia. Next, please. Okay. We might give trial of antidepressant if BBI failed. Amitriptyline, dipsparamine, low doses usually, not the one that we use for depression. Next. Prokinetic might help if they have early satiety symptoms, especially brocolide, metoclopramide, domperidone. They are a prokinetic agent. Erythromycin, antibiotic with a prokinetic agent. You can use it as a prokinetic drug, given half an hour to an hour before the meals, and herbal remedies as well. Next, please. And this is the new episode dyspepsia again. Referral criteria met, yes or no. Treat investigated dyspepsia, yes. Suspend NSAID. Endoscopy, upper GI malignancy. ما في non upper GI. You think about non-ulcer dyspepsia, gastroesophageal reflux treat. So this is the hierarchy how we approach a new onset dyspepsia in addition to that one. Okay, dyspepsia not needing referral, review medication, lifestyle, avoid smoking, coffee. هاي الأمور نفسها اللي نحكيها للبيبتيك ulcer disease. Stress, legumes, هاي الأمور اللي ممكن تضايق المريض. Onion, sometimes. Give them trial 4 to 6 weeks of PBI. If they improved, خلاص نضل ما في استغفر الله المؤمنين شر قتال. If they did not improve, we test for H. pylori, test and treat. If they did not improve, then we should send him to the GI eventually, but this is the not needing referral. ممكن نعطيهم prokinetic if no response, review again, and if we think that he needs referral now, we switch to the previous slide, which is the now he should be referred, okay? Plastic ulcer, this is a hierarchy as well. Stop NSAID if used. Test for H. pylori, negative. BBI 1 for 4 to 8 weeks, positive. Eradicate. The same again. Endoscopy, H. pylori test. Still re-eradicate. Ulcer healed. Low dose treatment, periodic review on this stuff. Not healed, endoscopy and GI referral to the specialist. Next. Same for the duodenal ulcer, you can read in your own time, and that's it. Any questions about the peptic ulcer disease? Okay, let's go through the esophageal